Thank you, Flora. I would like to express my thanks to the organizer of this meeting for inviting me to speak about congenital factor VII deficiency, which is one of the most frequent rare bleeding disorders. This is my declaration of interest. I have been working in the National Hemophilia Center in Slovakia, Bratislava, and in the population of 5.5 million inhabitants, we account almost 600 patients with factor VII deficiency, which is a huge number of the patients with deficiency, but you can see that not all are severe, of course. We are accounting 70 patients with a level below 2%, and altogether more than 100 patients with a factor VII level below 20%. From these numbers, you can imagine that dealing with patients with factor VII deficiency belongs to almost daily practice in my center, because we have to deal also with the patients with higher levels, cooperating with surgeons and so on who don't want to operate such a patient and so on. So, what we know about the congenital factor VII deficiency from the textbooks, we know that this is the most frequent rare bleeding disorders with very heterogeneous clinical manifestation, variable bleeding tendency, and it's well known that the factor level doesn't correlate very well with the clinical symptoms. There is also known or quoted in the literature that consanguinity increases the risk of homozygotes of this disease. A major progress has been done during the last 2 decades in the field of factor VII deficiency in terms of factor VII structure and function, in terms of molecular genetics, including the first gene mutation database which has been established in 2001 by McVeigh. Also, we know much more about the pathophysiology of factor VII deficiency, and there have been really some attempts on treatment recommendation by well-known authors, and I can say that the publication by Paula Bolton-Max is very useful in this field on rare bleeding disorders, and I would like to say that it was the most quoted paper during the last 2 years from the Hemophilia Journal. Congratulations. I think, and I'm sure that major progress could be done in the field of factor VII deficiency also thanks to existence of several types of registries on factor VII deficiency, including national registries. I mentioned Slovakian registry accounting almost 600 patients, and also in UK they are registering about 600 patients in their national hemophilia database, including rare bleeding disorders. A major contribution was done also by the several international registries of factor VII deficiency. I would like to point on the activity of International Registry Factor VII, Congenital Factor VII Deficiency, which is run by Professor Mariani. Also, Greifswald Factor VII Deficiency Registry, and recently developed registry, VII Therapy Evaluation Registry. Another field is also supplied by the International Rare Bleeding Disorders databases, including the WFH Hemophilia Annual Survey and Rare Bleeding Disorders, which is run by Flora. The World Federation of Hemophilia Global Surveys, yearly surveys, are very useful for us to know about the rare bleeding disorders, and you can see the proportion of factor VII in the latest survey released from 2010, and factor VII deficiency represents 23% of all the rare bleeding disorders, which now includes also platelet disorders. The total number of factor VII deficient patients reported in this survey was almost 5,000. However, you can see big differences in the prevalence of factor VII, ranging from 1 case to 60,000 inhabitants until more than 1 or 2 million inhabitants. What is interesting in this picture that the most prevalent or the highest prevalence of factor VII deficiency is reported in Slovakia, Hungary, Ireland and Oman. The highest is not reported from the countries with known consanguinity. We know that in Sudan the consanguinity approaches almost 50% in the population. So you can see big differences in the prevalence, but it depends upon the reporting. The cases, we don't know whether the cases have been reported according to the factor 7 level, or the symptomatic patient, asymptomatic, or the criteria of reporting. What about the function of factor 7? It's well known that the factor 7 has a very important role in the initiation of hemostasis, and this is very nicely presented in a picture published by Nigel Cree in Thrombosis Hemostasis, the position of factor 7, interaction with the tissue factor on the activated and non-activated cell surface, and the role of factor 7 in blood coagulation cascade. Nowadays we know the structure of the factor 7 containing 4 domains, and most important, of course, for the function is catalytic domain, which includes these 3 amino acids, including serine. It means the factor 7 belongs to serine proteases family. Mutations of factor 7 genes cause structure abnormality of factor 7, which is reflected by the decreased secretion or function of a protein, which is reflected in vitro by the decreased levels of factor 7 or antigen. It depends, upon this depends the CRM positivity, and it may be presented by symptoms of bleeding. At the level of factor 7 below 1 unit per ml, we can see either absent clotting in PT or delayed clotting in PT, and variable response in thrombin generation assay, which is not uniform. A lot is known now about the gene mutation in factor 7 deficiency, and they have been defined more than 130 mutation, mostly missense mutation in factor 7 deficiency. And again, my major contribution of International Registry of Factor 7 Deficiency group to knowledge about the genetics of factor 7 deficiency. In this group we have genotyped 313 patients. We have revealed 103 mutations, out of them 22 new mutations. And you can see the most prevalent mutation have been the ALAVAL 294 mutation in 67 patients, and mutation combined with deletion in 94 patients. There are known also several polymorphisms influencing the factor 7 plasma level. Out of them, there are many, out of them at least 5 polymorphisms or 5 of 7 may influence the expression of the factor 7 in plasma. There have been also observed some geographical differences in the distribution of factor 7 gene mutation. You can see that ALAVAL mutation is most frequent in the Central and North Europe. There are other mutations which are typical for several regions in the world. What is interesting that this mutation was described in Latin America by Greifswald registry, and this is not present in Europe, for instance. And what is interesting, this mutation ALA244VAL, which is very similar to ALAVAL 294, but this patient, despite having very low level factors 7, they are very frequently asymptomatic. What about the distribution of ALAVAL mutation in Europe? It was a major contribution of the Greifswald registry to this mutation, and you can see this mutation distributed like this, ALAVAL, but ALAVAL combined with deletion is distributed less frequently, and this mutation is very frequent in my country, in Slovakia, and we suppose that it's a founder effect. In 70 patients with severe factor 7 deficiency, 85% are homozygous for ALAVAL-del-C, and 92% are symptomatic. So this mutation is accompanied by symptoms. A lot of effort was done to study relationship between the gene defect and clinical phenotype in the factor VII deficiency, and the Greifels registry has shown that homozygous are mostly symptomatic, while heterozygous are mostly asymptomatic, but still some heterozygous are also symptomatic. North American registry showed that 40% heterozygous were symptomatic in this registry, and as far as I remember, Professor Manucci has commented in his publication this fact like surprising. But in our international registry, in our group, we have seen that many heterozygous can be symptomatic. You can see if we calculate this number, it's also substantial number of symptomatic heterozygous. And you can see something like genetic gradient that homozygous and double heterozygous are mostly symptomatic with severe phenotypes, moderate phenotypes, and asymptomatics are mostly homozygous. What about the clinical symptom of factor VII deficiency? We can see a wide variation of the clinical symptoms. We evaluated 313 patients, and these types of bleedings are considered as severe bleeding symptoms: hemarthrosis, muscle hematoma, GI bleeding, and CNS bleeding. They are not so frequent like the mucocutaneous bleedings. We have evaluated also the presentations of the symptoms by age, and you can see the most severe symptoms are presented very early in the life, including CNS bleeding. This is the age of patient, and these are the mean levels of factor VII in this patient group presenting with these symptoms. So you can see that the gum bleedings, epistaxis, and easy bruisings are presented later in the life. And what about the menorrhagia? Of course, it can be manifested at the age of menarche. I will speak a little bit about later. Recently, the joint effort of International Registry of Factor VII and VII Therapy Evaluation Registry has focused on the evaluation of a very large patient cohort involving more than 600 patients, and we evaluated the index period between 8 and 21 years. What means the index period is the follow-up period between the first symptom and enrollment in the registry, because we do have all the data about the patient during this period. This activity has been focused on the bleeding phenotype, the change of clinical phenotype during the life, because it's known that sometimes in the severe patients, severe symptomatic can become moderate symptomatic or asymptomatic and so on. And also we focus on the predictive value of factor VII level. Our group has distinguished two types of bleeding phenotype and one asymptomatic. One type is hemophilia-like, including severe bleeding symptoms. And age at diagnosis, mean age at diagnosis is 5.5 years. Most of these patients do have the factor VII level below 5%. Another type is so-called platelet-like, or we can say also the primary hemostasis-like symptoms, which is characterized by moderate or mild bleeding symptoms, these types. And age of diagnosis is about 10 years, and less proportion of patients, lower proportion of patients have such a low level of factor VII. Asymptomatic don't have any bleeding. Age of diagnosis is usually about 23.8 years, and usually it's in preoperative investigation or on the occasion of surgery. And the level, still also these patients do have a low level of factor VII in 14%. The presentation, you can see the proportion of this patient. Hemophilia-like or severe phenotype is present in 11% of patients. Half of patients do have platelet-like symptoms, and this proportion is asymptomatic at the diagnosis. What about the relationship between the factor VII level and bleeding symptoms at the diagnosis? We can see that the bleeding is related to the factor 7 level. The hemophilia-like bleeding types has the lowest level of factor 7, either at the disease presentation, either during the index period. However, if we accept the SD variation, we can see that there is some overlap between the levels, and some patient, even the severe deficiency can be mild, symptomatic, or even asymptomatic. What about the changes of phenotype during the life of the patient? It's also very interesting because we sometimes see the patient when we resolve the problems with menorrhagia and abdominal bleeding, ovulatory bleeding, and so on. The patient become to be asymptomatic. So in this evaluation of this joint activity of STER and International Registry, we can see that asymptomatic, the patient who are asymptomatic at the beginning or at the presentation of the disease, stay be asymptomatic during the observation period, but some of them are changing to mild or moderate bleeding phenotype. The patient who presented with platelet-like symptoms, some of them, very few, are becoming to be asymptomatic, but some of them may develop severe symptoms like GI bleeding, CNS, and so on. And a patient presenting with a hemophilia-like symptoms, it was a group of 77 patients. Some of them stayed to be severe phenotype, some become mild phenotype patients, and very few become to be asymptomatic. So we can say that there is some relationship between the factor level and bleeding phenotype, and the risk of bleeding is given by the risk ratio 2.4, at this level more than 26%, and 6.2 at the level below 3%. And the risk of severe bleeding is much more higher, of course. What about the gynecological bleeding? It was a matter of a lot of discussions in our group, because I do have a lot of experience with gynecological bleeding in my patients, and I consider it like severe symptoms. However, my colleagues used to say it's mild symptom, or it's platelet-like, or it's a moderate symptom, and so on. Of course, this bleeding starts later on in the life, not so early like a CNS bleeding, but about this year. But maybe life-threatening. I do have such experience. It's not only menorrhagia, but it's also ovulatory bleeding, intra-abdominal bleeding, and postpartum bleeding, of course. So, in our group of patients, in 31 females with severe factor 7 deficiency in my center, we have seen at MENARC 74 girls do have excessive bleeding at the start of MENARC, and acute anemia, post-hemorrhagic anemia developed in 44% of patients. So we are very much afraid of this period in our patients. And during reproductive age, we can see that menorrhagia in this severity of factor 7 deficiency is almost in 92% of patients. They do have acute anemia during their life, chronic iron deficiency, and many of them develop ovarian cysts, and many we don't reveal of them, and almost 20% of my patients had life-threatening, serious intra-abdominal ovulatory bleeding. The same we have observed in our group International Registry. We evaluated 34 patients with severe factor 7 deficiency, and you can see the numbers are very similar to the group of my patients, with very frequent menorrhagia, ovulatory bleeding, ovarian cyst, intra-abdominal bleeding, and many of patients had to undergo hysterectomy, ovariectomy, mostly from the period with lower availability of factor concentrates. Risk of surgery in this patient group is 1.6, almost 1.6, and it was significant difference between these two groups concerning the risk of surgery. So this group is in very high risk of necessity of gynecological surgery. Factor replacement in factor VII deficiency is aimed for therapy of bleeding or prevention of bleeding, and these are the products which are available, including fresh frozen plasma, recommended dosages which are limited by the volume, PCC, and nowadays mostly plasma-derived factor VII has been used, and recombinant factor VIIa. These are the recommended dosages, and which is interesting that plasma-derived factor VII has very good incremental response, so we don't need such a high dosages like factor VIII, and these are common dosages, initial dosages, then we can decrease, and incremental response of factor VIIa can be calculated by dosage per unit per kilo or microgram per kilogram, and this is the result. What about the surgery in factor VII deficiency? It's a really major issue, and there have been several publications published on this issue, and it used to be said that minimum postoperative level is more than 20% until healing. It was one very interesting publication by Canadian authors published who have shown that in vitro very low concentrations of 7A is sufficient for normal hemostasis, which represents dose of recombinant factor 7A 1.8 microgram per kilogram. But this is a question mark, because we don't know whether it works also in vivo. In vivo, it was one observation in one individual after the dosage 23 microgram per kilo. Still 24 hours after this dosage was normal thrombin generation, but we don't know what about surgery in this patient. One interesting paper was published in 2005 by French authors who reviewed the surgery in 17 patients, which was done without factor replacement. And they have observed 35% of bleeding episode, but even some patients with a lower level than 1% haven't bled. So these authors concluded that minor surgery can be performed in patients who have been previously asymptomatic without replacement, regardless factor VII level. However, the same group has re-evaluated their opinion later on in 2011, very nice paper, retrospective study evaluating 157 surgeries in 83 patients with this level of factor VII without replacement, bleeding rate like this, and they said that perioperative management should be based not only on the thorough bleeding history and symptomatic and asymptomatic, or the type of surgery, but also based on the factor VII level, which the safe threshold is 10%. So they have re-evaluated their previous opinion. In my center, we have performed many surgeries, and this is a period of 15 years. We performed 137 surgeries in 74 patients. Out of them, almost 70 surgeries in severe factor VII deficiency patients. The bleeding rate in my patient was 8, representing 5.8%, despite the replacement therapy, and you can see the different type of, many of these surgeries were major, 72 major surgeries. This is a protocol we have been using in my center for factor replacement, using recombinant factor VIIa and using plasma-derived factor VIII. The most important is that during the first 3 days we are using 4 doses per day. Then after continuing 3 dosages, and according to type of surgery we continue until day 9, 10, 12. It depends upon the type of surgery. It's really the question whether it is necessary to the replacement therapy so long, because we know that the factor VII is very important for the initial hemostasis, and it is questionable whether it is necessary so long to treat the patient. But some patients experience bleeding on day 7, on day 9, when we stop the treatment. So it is really very hard to decide what to do. And you can see here the differences between the response on factor replacement by recombinant factor VIIa and plasma-derived factor VII. Using plasma-derived factor VII, we are moving between the range of 40% and below 100%. We don't need more than 100% because hemostatic level of factor VII is very low. But using recombinant factor VIIa, we are achieving very high levels, but due to very short half-life, the factor level is going very quickly down. And what we have observed that at the same dosages, the trough levels were decreasing during the treatment period. We have compared the factor VIIa treatment for surgery in 15 surgeries used by bolus injection and continuous infusion, which is now has been used also by Norway authors. And I would like to point on the first publication on the prospective multicenter observation study in factor VII deficiency, concluding that the first dose shouldn't be less than 13 microgram per kilogram and not less than 3 doses per day. So the last topic is prophylaxis. I just want to mention that the prophylaxis have been done already, and now the prophylaxis with recombinant factor VIIa is going on in several patients, and long-term prophylaxis should be considered in all patients with severe bleeding and recurrent bleeding. I would like to conclude my presentation with some messages that major progress has been done in the recent period in our knowledge of factor VII deficiency, and maybe there is the time to develop some relevant guidelines for the treatment of these rare bleeding disorders. Thank you very much.